you here. I'm passionate about this stuff. Lots of people have died. Lots of people have given their lives for my country and many others. I spent the first part of my career was spent basically in places like this, Air Force Combat Support Hospitals. And though this quote gets changed, the only one who benefits from war is the young surgeon, as to whether it was Socrates or LeRay, or who was the first one to say that. I truly believe that that's true, and I am one of those young surgeons who truly benefited in learning, in caring for some of the most horrific wounds of war. And now we have to take those lessons that are learned and we have to apply that to civilian trauma centers. Because I don't get to spend any time here anymore. It seemed that Tim and I spent most of our time here some years ago. Now I work here at the University of Missouri Trauma Center and try to apply what we've learned to the care for people within this building. So times of conflict really do give us generational leaps in our understanding of trauma care. Whether you look at the changes after the Korean War, after the Vietnam War, we get significant increase in our understanding, and we have to apply those to the benefits of civilian injury care. So I'm just going to get straight into it, since I knew we were talking to some pre-hospital groups today. Tourniquets. The concept's been around forever. Here's 1941, the discussion of surgery in modern warfare and tourniquet use. Used rather extensively in World War II. And then the bulletin of the U.S. Army Medical Department towards the end in 45, problems with the tourniquet, and then followed by Sir Watson Jones, probably the most prolific orthopedic surgeon in the world. Started the Journal of Bone and Joint Surgery, was its first editor, was seeing wounds back at the hospital in England, not off the battlefield, and basically banned the use of tourniquets. And that concept, that tourniquets were bad, stuck. And it stayed for a very, very long time. This is the emergency action tourniquet or the combat action tourniquet. It's everywhere. You'll notice you keep your weapon and your tourniquet, at least what you carry your weapon with, right next to one another. When they get a little dirty, you clean them up and get them ready to go out another time. And they are extremely effective, taking individuals like this to the cover of Esquire magazine and saving lives. In this case, not limbs, but saving lives. Multiple tourniquets in the combat support hospital are very, very common, with multiple injuries. And almost all casualties that needed to see me, a surgeon, would present with tourniquets on, whether needed or not needed. They clearly save lives. And they clearly save limbs, which is not what was taught for many, many years. When you look at what's been written in the medical literature, practical use of emergency tourniquets to stop bleeding and major limb trauma. John's probably the most prolific military that has pushed the use of tourniquets. He's done an extensive job at looking, coming into the combat support hospital in Baghdad, how were things different based on tourniquet use? And it's most easily to see, if you had your tourniquet placed pre-hospital, you were more likely to survive than if you had it placed in the emergency department. In his numbers, 31 lives were saved by putting it on in the field rather than waiting until it arrived at a hospital, and putting it on early in the field. So if you had your tourniquet placed prior to the onset of hemorrhagic shock, this is your survival curve. If you have it placed after the onset of hemorrhagic shock, this is your survival curve. So very simply, tourniquet application from the Israelis, effective, easily applied by medical or non-medical. How many non-medical personnel do we have in here today? Any? Or is everybody medical? We got a few non-medical, right? It's not hard to do. It doesn't take long to learn how to put on a combat action tourniquet. However, the controversy continues. A recently written article in the Journal of Trauma about the maybe I press this one. Jason? There we go. I found it. know which button not to push anymore. All right, the tourniquet controversy. And here's from the Canadians, just looking at tourniquet use for peripheral vascular injuries in the civilian setting. You know, in civilian trauma, major exsanguinating peripheral vascular injury is uncommon. We probably see most of it related to farm injuries in the auger in the center of the United States. There's some industrial-based injuries, but you just don't see those wounds to the extremities that you see related to combat trauma. The guidelines for use and the medical control varies in the civilian sector. A lot of the use is not data-driven, the way John Crogg takes care of things than the way it was looked at in the past. But clearly, you can see the pictures from Boston. It not only saved lives, it saved limbs. So I think you will find that tourniquets should in fact be used by pre-hospital personnel. They save both lives and limbs. It's not life over limb. They are most effective when applied early and most effective prior to the onset of hemorrhagic shock. Vascular shunts. Didn't know if we'd have any surgeons in the room, so we got to talk about shunts. You know, the first shunt was written about at the University of Cincinnati in the 30s or 40s, where someone had a ruptured abdominal aortic aneurysm. They sewed in an old tube and just closed the patient, and the guy lived. And shunts have been used in surgery for a long time as temporary and for definitive control of things. When you look at far forward care of extremity vascular trauma, first and foremost, we stop the bleeding. We'd like to restore blood flow if we can, but cessation of hemorrhage is most important. We want to remove any contamination that we can from that wound. We want to be able to stabilize a fracture, and we don't want to burn a bridge for the next guy as we move someone through the system of care. And even when this is one of my cases in the hospital in Missouri, even in the hospital in Missouri with all these loops on, control of a vessel can be difficult, right? That's a big bloody mess. We're supposed to be able to see things in that picture. So here's a picture of a fairly significant injury to the femoral artery that has been nicely shunted with an inline shunt. You can see the rather large segment that is missing from the femoral artery. The distal extremity is perfused. It's allowed us to debride this wound and move this patient to a higher level of care. Same idea here with both an arterial. This is probably the best picture I have, where you can actually see the red blood headed to the foot and the less red blood headed back to the heart, right? So shunting both, especially in the SFA, and this is the superficial femoral artery and vein, especially in the SFA, being able to shunt both artery and vein made the patency of the arterial shunt stay open longer. So with the high number of injuries to the superficial femoral artery and vein, many people became experts at putting these things in, giving us time to debride, time to do other things, time to resuscitate the patient, and getting the patient to the ideal location to do this rather complex vascular reconstruction. But it can be done anywhere. This is an arm that was brought to me in about 2005 or 2006, just north of Baghdad. This shunt that basically goes from the axillary artery to the brachial artery was placed by a Marine surgeon who had finished her surgical training in June. This was July. Did it at night in a tent by herself and then did fasciotomies. We were unable to salvage this limb, but this provided, as you can see, adequate blood supply to the upper extremity while this patient was moved to a place that the wound could be better assessed. No bridges were burnt. The limb was cut off by me, but no bridges were burnt, and this was placed in a rather austere environment. So some technical points: they should be a straight lie of the shunts. They make a number of shunts that will curve and loop. For these, coming off the battlefield, you want a straight lie to minimize stasis and turbulence, because we leave them in a little longer than we might doing elective surgery. It also increases the stability of placement, and it ensures that the end is not facing towards a wall. We want to leave the native vessels intact. We want to avoid some retraction. We want to ligate some of the side branches that are close to the tributaries, but leave as much intact as we can, and then secure them as close to the midline to allow, once again, not burning any bridges for the next guy who's a little bit further down the road. They restore blood flow early. They limit ischemic time and reperfusion injury. They can be placed prior to transport. I know of at least 2 shunts that have been left in place from Afghanistan to Germany because it was felt that their vascular reconstruction was a bit complex to go on at Bagram at the time. So why not rural centers? Or I had quite a drive coming down the coast. Why not some of the rural centers having the ability to place a shunt if you're only going to have 2 or 3 major trauma centers in the country? Be able to shunt an extremity prior to transport to get to where you need to do your major reconstruction here in Ireland. It allows for fracture manipulation, debridement prior to definitive vascular repair, and I think it should be a part of every surgeon's playbook, or based on your logistics and how you're going to care for someone, maybe someone else's playbook in order to allow for perfusion of the extremity. Clotting adjuncts in the field, been around for a long time. Do they work? So, advanced hemostatic development program, animal model selection. There is now so much work that has gone to this. There are 2 standardized animal wounding patterns to test your device to see whether it is worth the United States government playing with your device. It all kind of started before the war, actually. It was something called the American Red Cross, or the ARC dressing, which was factor 13 and fibrinogen, and a number of other blood products put on a standard 4x4, unbelievably expensive to produce. It was actually taken to Baghdad in 2003. The guy who deployed only used it on 1 patient, left, no one else had signed the IRB paperwork, nothing else was done with that, and we stopped hearing about the American Red Cross dressing. But then there's an explosion of products on the market with a number of companies attempting to come up with something that will work to stop battlefield hemorrhage. Some of those that got early publication and early publicity and got bought in large quantities and deployed with the HemeCon dressing, which is a chitosan dressing. This one's from shrimp shells. It's a 4x4. It's adherent. It's got incredibly long shelf life. And it's probably a little bit better than gauze on a flat planar surface. How many flat planar surfaces do you see after someone gets blown up? There's not many of them. Same thing was the RDH, or the rapidly deployable hemostatic bandage. It was marine microalgae rather than shrimp, concentrated platelets and clotting factors based on charges, reduced blood loss, reduced volume requirement, but again, it's a flat dressing. Most wounds are not flat. And you saw quick clot. At this time, quick clot was volcanic rock. It was inert. It's a desiccant. It was cheap. It had a forever shelf life. If you look at what happened in Afghanistan early, it was almost used early on as punishment for bad guys that we were taking care of. And then when special operations medics saw how effective it was at stopping hemorrhage, it suddenly started being used on Americans. It was a very aggressive groin junctional swine-based model that brought quick clot to its fame, and there was 0 mortality in the swine that underwent that wounding pattern. So it was then deployed with Dr. Copley as part of the Marine Hemorrhage Control Kit. Remember that, Tim?
Oh, yeah.
Where everybody got 2 of these and went out and used them. It had some problems. It would embolize distally. It would get into vessels. It would cause rather significant exothermic reaction. It was a dehydrating agent, very effective at stopping hemorrhage, but very difficult to use. Imagine putting cat litter into a fountain and trying to make the fountain stop flowing with cat litter. So there's been a number of different things done. This is the most recent comparison of all hemostatic dressings. And the biggest line is the lack of clear superiority of any agent suggests that contemporary hemostatic dressing technology has potentially reached a plateau for efficacy. So the current recommendations from the other side of the pond are the use of combat gauze, Quick Clot's newest version that is not volcanic rock based. It's kaolin based. It's a 3-inch by 4-yard roll. Requires good wound care and packing technique. To sum up hemostatic dressings, they're all probably better than gauze. We've had gauze since about the Crimean War. I think it's about time we got something a little bit better. There's no clearly superior agent. likely dependent on wounding site and wounding patterns, but the ability to pack rather than having to put a flat planar surface on a wound is probably important, which is why combat gauze remains the #1 choice with the United States Department of Defense. There is an accelerated use. There are hundreds of different items in civilian trauma care and pre-hospital care. They're all recommended for external use. We have used many of these internally. They work well. Many have been tested in a very large swine liver injury model. Some are nitric oxide scavengers, some are not. They do some interesting things. For the most part, they're all better than gauze. You're going to see more and more of them, but nothing beats good wound care and good tourniquet application. What I believe is the biggest, and I'm going to talk about doing it pre-hospital tomorrow in 6 minutes and 40 seconds, the damage control resuscitation. I think this is the biggest change to how we care for people in modern history, probably in the last 60, 70 years. The return to the concept of the use of whole blood as a target for resuscitation, doing it early, and some of the adjuncts that come with that, some of the drugs and some of the adjuncts, some of which are new drugs, some of which are old drugs, has probably had the greatest impact on survival. If you look at what Holcomb did at the 31st Combat Support Hospital early on in the war, he looked at who got transfused. So of the 4,500 trauma admissions that came to that Army Combat Support Hospital, about 1,000 got transfused. But that means they got 1 unit of blood, and we're trauma surgeons, we don't get excited over 1 unit of blood. 5.4% of them got a massive transfusion, meaning they got more than 10 units of blood product in the first 6 hours. That's what gets us excited. That's why we get up in the morning to take care of those patients. Most patients don't get it, but the sickest ones do. It's about double the major inner-city civilian experience. So if you compared this to a major inner-city hospital in the United States, 5.4% coming off the battlefield. It's about 2.5 to 3% major inner city trauma. So the level 3 mortality, which is the big combat support hospitals, in patients who got a massive transfusion, that more than 10 units, is 1 in 4. So this is a place you can have significant impact on mortality if you can make a difference. And the difference is, which one do I use? How do I start? When do I stop? And how do I make the human being better? So we know that whether you talk about military casualties or civilian casualties, as the number of units of blood products goes up, the mortality rate goes up. And it goes up linearly. So what we want to do is stop hemorrhage and do whatever we can to terminate hemorrhage so that we can transfuse less blood. Well, it turns out, if you start by transfusing blood, you will overall use fewer units of blood in your resuscitation of your casualty. So this concept of warm, fresh, whole blood independently associated with improved survival with combat-related injuries demonstrated that when we used warm, fresh, whole blood, which we do not have access to, but a trial currently going on at some of our inner-city centers, we saw improved outcomes because you got everything you needed, it was warm, and it was immediate. And this concept of guiding a ratio, so fixed ratio resuscitation, targeting a 1-to-1 ratio of plaque red blood cells to plasma. Why was all the early work done on 1-to-1 plaque red blood cells to plasma and nothing about platelets? Because there were no platelets in Iraq and there were no platelets in Afghanistan. They have to be continuously agitated and refrigerated. So all the early work was done without it. The current work, which we'll talk about more tomorrow, being done with where do we bring platelets into this. But we know that increased FFP transfusions within the first 24 hours of admission for those that are the most severely injured are independently associated with increased survival. And we know that the median ratio when we look at combat casualties of FFP to red blood cells of 1 to 1.7 compared to 1 to 3 in non-survivors was very significant. So if you just break it down and make it simple, for combat casualties, a 4-to-1 ratio of red cells to plasma, mortality rate is about 60%. And you see a linear reduction in mortality as we target 1-to-1 resuscitation in those that are injured on the battlefield. Multi-system organ failure is lower when we start with predefined transfusion protocols that are targeting this 1-to-1 ratio. You very rarely achieve it, but you come close to targeting it. We have reductions in organ failure and post-injury complications. 30-day survival rates are significantly higher in those who have a fixed ratio massive transfusion targeting this 1-to-1. And the earlier we start it, again, for those in the pre-hospital environment, the better. So how do we resuscitate someone? It's really not the hole in the blood vessel. That's easy. Guys like me take care of that. We put a stitch in. What we need to do is correct trauma-induced coagulopathy. We need to reverse that systemic endothelial injury. There's some emerging literature that would suggest that plasma is maybe more than just a clotting agent and a volume expander, that it's actually correcting some things through the thousands of proteins and protein interactions at tight junctions and gap junctions within endothelial cells. It may reverse that systemic endothelial injury and reverse permeability, dampen the systemic inflammatory response while restoring oxygen delivery, which is our goal when we're taking care of these individuals. There are some specific additional treatments. TXA, or tranexamic acid, a fibrinolysis inhibitor that blocks plasminogen binding to and then inhibiting plasmin production. So we don't continue to deplete fibrinogen. Lots of trials. The MATTERS trial, the British looking at what was going on in Afghanistan and those coming through a single combat support hospital in Afghanistan. The CRASH 1 and CRASH 2 trials done throughout Europe all show benefit of the use of TXA. It's best, again, if given early, within an hour of injury. Remains effective if it's given within 1 to 3 hours of injury. There are significant reductions in mortality with its use, especially in the most severely injured. Get a gram load and a gram over 8 hours. It's cheap, it's an old drug, and it was approved in 2011 by the Tactical Combat Casualty Care Committee for use on Americans based on all of that data. And that's a hard group to get to agree on anything, okay? So, this concept of hemostatic resuscitation or damage control resuscitation needs an early diagnosis in the field or immediately upon arrival. Need massive transfusion protocols with fixed ratios. Shouldn't be having discussions about what product you're going to give at what rate when someone's dying. You have it fixed ahead of time and you're going to go ahead and give the casualty what they need. And then the use of adjuncts like tranexamic acid or TXA, the immediate availability of FFP, frequent platelets and cryo. The current PROMIT and PROPER trials that are going on in the United States will likely give us an answer, but we likely underdose platelets as we do these 1-to-1 resuscitations. And then none of this works if we have a saltwater drowning that takes place in the process. So we need to minimize crystalloid delivery as we do this. So early diagnosis in the field, massive transfusion controls and fixed ratios make things better. Immediately available, the simultaneous restoration of coagulation and intravascular volume deficit while gaining hemorrhage control. And the last piece I want to talk about today is patient movement. Tim knows I had spent quite a bit of time figuring out how and teaching others how to move casualties globally and move them quickly. If you looked at the historical route, meaning Vietnam and the first Gulf War, 1 day to get to a field hospital and you were getting the job done. 7 days to get to an in-theater hospital, places like Baghdad and Balad where we were, where those studies were done. And 15 days to get evacuated back to what is now Germany or back to the United States. The average amount of time it took to get a casualty back from Vietnam was 48 days. And that's just unacceptable in today's very fluid environment. So the Gulf War gave us a problem. It was very non-linear and very fluid, and you would actually have troops further away than you could reach them from the cache. No longer could medical personnel just be in the rear with the gear. So you had to figure out how to be lightweight, lean, and mobile, and how to be austere but adequate. How do you provide the appropriate amount of care but then rapidly move individuals by moving pieces of the hospital with the troops and having the ability to rapidly move them. So the patient evacuation system at the start in 2001, 2002 was a remnant of Vietnam. It was designed to move very stable patients because if you looked in southern Vietnam and in the Philippines, there were huge hospitals built and no one came home until they basically walked on the airplane from the United States. The people transporting may not be current in critical care, and a normal crew is 2 nurses and 3 med techs that may be caring for 60 patients at a time. This is not someone who can actually move someone who is sick. And we paid for it. So you saw after the first Gulf War, joint medical support, are we asleep at the switch? And I think we were. So the new priority was to provide essential care far forward. The mantra of austere but adequate came out with the emphasis on patient movement. You had to evacuate and replace, stabilize, and then move when not necessarily stable. Everything needed to be modular, and we needed a critical care evacuation system. So now you developed a new problem. You got a guy who's stable sitting in here, but it's really hard to provide that level of resource intensity that a combat casualty needs in that tent. So the solution was the CCAT, or the Critical Care Air Transport Team, which took from a number of specialties a critical care physician with a critical care nurse and a cardiopulmonary technician, and put together a group that could move the sickest of casualties, up to 6 at a time, anywhere in the world, regardless of what was wrong with them. And now you saw a system that was now, before 22 days by mantra, now an hour with Casavat to a forward surgical team, within a 1 to 24 hours to a combat support hospital where I spent most of my time, and within 72 hours to definitive care, pushing the surgical and the care further forward to the point of wounding and more rapidly evacuating individuals back for definitive care. This has huge implications to the way we care for civilian trauma, especially in the United States, where politics and ability to pay seems to drive where patients end up. I had the benefit of going back. This is one of the neatest things I've done. I went back in February without a uniform on, and I think this gives a perfect example of how this system works. There's a vehicle-borne IED in Pakistan. There were 3 killed in action and 6 wounded within the special operations community. From Pakistan, they went to Afghanistan. They had their initial operation done by a Canadian team in Kandahar. They then took a C-130 to Bagram and had an Air Force team do their second operation in Bagram. Then a C-17 to Germany, where they had another operation. And then a C-17 to the United States. Total time from wounding to arrival was 3.5 days. And I had the benefit of meeting Staff Sergeant Lee. Staff Sergeant Lee's father was a volunteer minister in Europe. So his parents joined us, and I became the medical attendant that helped fly Staff Sergeant Lee with the Mississippi Air National Guard to Ramstein Air Force, from Ramstein to San Antonio, Texas, with this being our CCAT team. So this individual 3 days ago was wounded in Pakistan, has now been operated in Afghanistan and in Germany, and is on his way to definitive care in Texas. He did very, very well. I got nice thank you notes from his mom and dad. And the question is, how do we take successes like Staff Sergeant Lee with this staged en route care with rapid transport of patients and apply that to civilian trauma care? How do you do that in Ireland that's only going to have 2 trauma centers? So it requires us to think outside of our comfort zone. No one is too sick to move. If hemorrhage is controlled, no one is too sick to move. It requires a system in place in which patient movement is based on patient needs, not someone's ability to pay. And it's seeing more and more damage control done in the austere or the rural setting. And then we're seeing it in Missouri, where there's a solo general surgeon that will actually do some damage control procedure and then very rapidly call for our critical care transport team to go get that patient and bring them to Missouri. It saves lives, it gives earlier hemorrhage control, and in a mature system like the military has, you can see that you can move people great distances with great outcomes in a very short amount of time. This is a neat article from last year. Tourniquets, hemostatic agents, and tactical medical care are the integral components of battlefield medicine and have been life-saving in these settings. The barriers to this transition are multifactorial. Physicians familiar with these technologies should become advocates for their integration in civilian trauma patient care. This is about integrating in California. I think it's the same in Ireland. It's the same in Missouri. There are some of us who have a unique understanding of how this will benefit civilian patients' lives. And it's up to us to be the advocates, to push it forward, and make people do things a little bit differently than they've been used to for the long time in their career. So remember, tourniquets save lives and limbs, and the earlier they're on, the better. Vascular shunts save limbs and lives and can be done in the austere environment and may buy you time on saving that limb. Hemostatic dressings are clearly gaining acceptance. They're all superior to gauze. It's probably wounding pattern dependent which one is best in which application. Damage control resuscitation, in my estimation, is the greatest change in trauma care in the last 60 or 70 years. Clearly the greatest patient benefit. And patient movement, you got to get the right patient to the right place in the right amount of time. I want to thank everyone very much for having me here today, and I'd be happy to answer any questions. Thank you.